A 40-year-old man comes to his physician due to recent breast tenderness and enlargement. A few months ago, he was prescribed medication after a visit for upper abdominal pain. He has a history of parathyroidectomy to remove parathyroid adenomas. Which of the following is most likely mechanism of action of the drug this patient was prescribed? Choice A, both agonizes and antagonizes GnRH receptors. Choice B, competitively antagonizes the aldosterone receptor. Choice C, inhibits a P450 methylation reaction. Choice D, blocks stimulation of histamine 2 receptors. Or choice E, inhibits function of hydrogen potassium ATPase. I'll wait 5 seconds and then answer the question. This shouldn't be too hard of a question. This is one of those pretty well-known drug side effects. This patient has peptic ulcers, and he was prescribed most likely cimetidine, an H2 blocker. Choice D is the correct answer. Cimetidine, of course, is well known for causing gynecomastia, so obviously it can be used for treating peptic ulcers like this. Cimetidine is also a P450 inhibitor. That might come up, but unlikely, I think. Some of you might be wondering about the parathyroid adenoma detail in this question. It's not necessary to answer the question. I mostly just put it here so you have an idea of what MEN type 1 might look like on the exam. They'll do stuff like this, or they'll give you a patient who has a history of tumors, and then they'll come back and have some other kind of tumor, and then they'll ask you what kind of mutation might this patient have, that sort of thing. Obviously, in this case, MEN type 1, that would be MEN mutation, as opposed to the RET gene, that is for MEN type 2. And just for a quick review, MEN type 1 is, of course, pituitary adenoma, parathyroid hyperplasia, and some kind of pancreatic tumor that can present in a number of different ways. It can be an insulinoma, it can be a glucagonoma. So obviously in those cases you would have either hyperglycemia or hypoglycemia, that sort of thing. VIPoma, which of course would be just tons and tons of diarrhea. And in this case you have a gastrin secreting tumor, which is Zollinger-Ellison syndrome. And just for further review, MEN type 2A, of course, is parathyroid hyperplasia, medullary thyroid carcinoma, and pheochromocytoma, whereas MEN type 2B is mucosal neuromas, marfanoid body habitus, medullary thyroid carcinoma, and pheochromocytoma. So let's look at some of the other answer choices here. Choice A, both agonizes and antagonizes GnRH receptors. This is referring to leuprolide, which is a GnRH analog. So of course, if you know how GnRH works, which is that in order for it to function properly and actually increase LH-FSH levels, it needs to have pulsatile release, then you'll understand why leuprolide also can both agonize and antagonize, or increase or decrease LH-FSH release. So when you first give leuprolide, it might increase LH-FSH, but if you keep giving it without stopping, it can decrease levels. So leuprolide can be used for a number of cancers which are hormone dependent, such as prostate cancer, sometimes breast cancer. It can also be used in precocious puberty and gender affirming care. So as you can imagine, since GnRH affects, well, your sexual development, then of course leuprolide can potentially cause gynecomastia, but you don't use it for peptic ulcers, so obviously that's the wrong answer. Choice B competitively antagonizes the aldosterone receptor. This is spironolactone, a potassium-sparing diuretic, which is also well known for causing gynecomastia. That has actually come up pretty often, I think. You need to know spironolactone can do that. So obviously as a potassium-sparing diuretic, you use it for all kinds of fluid overload situations, heart failure, you can use it for hypertension. Sometimes they might ask you that a patient is already on a loop diuretic, and then they ask you what other diuretic can we add to this patient. And because we already know they're taking a diuretic that might cause a drop in potassium, we need to give them a potassium sparing diuretic, such as spironolactone. The other aldosterone receptor antagonist is iplerenone. I don't think it really comes up anymore. And as far as potassium-sparing diuretics go, obviously you also have the ENaC blockers, which is triamterene and amiloride. You need to know those as well. So obviously these are diuretics, nothing to do with peptic ulcers. Choice C inhibits a P450 methylation reaction. This is kind of an obscure way of describing the azoles for antifungals, but they've actually written this to imply azoles on the exam before. They use some kind of variation of this. They'll say like methylation reaction, P450 reaction. So anyway, ketoconazole is one of the azoles and is also well known for causing gynecomastia, but obviously these are antifungals and don't treat peptic ulcers. As far as what azoles are used for, they're used for a variety of local mycoses. Probably too many to list here. The big difference, obviously, you want to draw here is versus systemic fungal infections, in which case you are more likely to use amphotericin B. Choice E inhibits function of hydrogen potassium ATPase. Again, I was just trying to be vague on purpose. This is, of course, referring to proton pump inhibitors. That's the proton pump. And, of course, they are also used for treating peptic ulcers, but in this case, they do not cause gynecomastia. So obviously I threw in some bonus points here, but I guess the main thrust of this question is really just know cimetidine, know that it's an H2 receptor blocker, and know that it can cause gynecomastia. But hopefully I gave you some other unrelated details that will be helpful as well. So I hope you learned something from this video, and I'll see you in the next one.